We often don't think much about what's going on inside our teeth until, well, suddenly there's a problem.
Right. Out of sight, out of mind, usually.
Exactly. But it turns out there's this whole fascinating world within each tooth, the dental pulp, and how dentists keep it healthy or fix it when things go wrong is a real blend of biology and, frankly, some pretty ingenious techniques.
It really is a delicate balance.
So today we're taking a deep dive into this. We've got a comprehensive PDF guide on pulp therapy, and our mission really is to unravel the key differences between dealing with unhealthy pulp and, keeping healthy pulp thriving.
Especially in those tricky cases, baby teeth and young permanent teeth that are still developing.
Yeah, we want to make it clear when a tooth's inner workings can actually bounce back and when more serious steps are needed.
Think of it like this. The pulp is the tooth's inner core. Sometimes it gets a bit irritated, maybe a minor inflammation. It can recover. Other times, it gets seriously damaged. And that's a different story.
Yeah.
Understanding that difference, that fork in the road, is crucial. It dictates everything that follows.
Okay, so let's get into that fork in the road. Understanding when things are just irritated versus seriously damaged. Our source talks about pulpitis, and it makes this really important distinction right away. Reversible versus irreversible pulpitis.
Exactly. The names kind of give it away.
Right. Reversible pulpitis, the pulp's inflamed, but the good news is it can heal. So what are the telltale signs? How do we know it can recover?
Well, with reversible pulpitis, you're typically looking at provoked pain.
Provoked, meaning?
Meaning it needs a trigger. Something hot, cold, maybe sweet hits the tooth, and you get this sharp but usually short-lived sensation.
Yeah.
It generally disappears pretty quickly once you remove the trigger.
Ah, okay. Like that quick zing from ice cream, but maybe a bit more intense.
Sort of, yeah. It's that kind of fleeting sensitivity. The key is that it doesn't linger.
So it's not that constant throbbing ache that makes you want to bang your head against the wall.
Exactly. It's more of a here-and-gone situation.
Yeah.
And clinically, when a dentist examines it, we wouldn't expect spontaneous pain that just pops up for no reason.
Right.
And you shouldn't see things like a sinus tract, that little pimple on the gum where infection drains, or excessive wobbliness of the tooth, unless, it's a baby tooth getting ready to fall out or there was a recent bump.
Got it. So the dentist is going to be asking a lot of detailed questions then. About the pain, what it feels like when it happens.
Oh, absolutely. That history is vital. When did it start? What sets it off? How long does it last? What makes it better or worse? All crucial clues.
And then they look?
Then comes the objective exam. Looking closely at the teeth, the gums, maybe taking some x-rays to see beneath the surface. They might gently tap on the tooth, check for mobility.
What about those zappy tests, the cold spray or the electric thing?
Yeah, thermal tests and electric pulp tests. Interestingly, our source notes, they aren't always reliable in primary teeth or those young, immature, or permanent teeth. Their nerves just don't respond the same way yet.
Huh, okay. Good to know. So that's reversible, manageable. But what about when it's beyond that? Irreversible pulpitis, what does that look and feel like?
Right. Irreversible means the pulp is significantly inflamed, and unfortunately, it just can't heal itself. The symptoms tend to be much more intense, more persistent, like spontaneous pain, the kind that can just start up any time, maybe wakes you up at night, unprovoked.
Ouch. Okay.
You might see that sinus tract we mentioned, or swelling in the gums that isn't just simple gum disease. The tooth might even feel loose, again, without an obvious reason like trauma or normal shedding.
That definitely sounds more worrisome. Are there other signs, things you see on the x-ray?
Yes. An x-ray might show a dark area, what we call a radiolucency, around the tip of the root or between the roots.
Yeah.
That often signals infection spreading into the bone.
Okay.
We might also see signs that the tooth structure itself is breaking down, either from the inside out, internal resorption, or from the outside in external resorption. Those are red flags.
So diagnosing irreversible pulpitis involves piecing together those more severe symptoms and really looking closely at the x-rays.
Exactly. The history focuses on that spontaneous, severe pain. The clinical exam looks for those signs of inflammation, maybe even pulp death. And the radiographs become critical for seeing those deeper changes, the resorption or the bone issues.
So the big difference is the pulp's own defense system is overwhelmed, often by bacteria, and it just can't fix itself anymore.
Precisely. And at that point, the treatment goal has to shift. It's no longer about saving the pulp. It's about eliminating the source of the problem, the damaged pulp, and the infection.
Okay, so that distinction, reversible versus irreversible, is the absolute key. If it is reversible, the goal is keeping the pulp alive and healthy. What's the overall approach there called?
That whole category is called vital pulp therapy, keeping the vitality.
Makes sense.
The aim is, like you said, preserve the pulp's life, help it heal, encourage it to form more protective dentin, um, keep bacteria out, and obviously avoid any problems after treatment, like pain or swelling.
Kind of like first aid for the inside of the tooth.
That's a good way to put it. Clean it up, protect it, let the body do its repair work.
So when is this not an option? When can't you do vital pulp therapy?
Well, the source lists clear contraindications. If the pulp is already irreversibly inflamed or, worse, necrotic, meaning dead tissue, vital therapy won't work. It's too late.
Right.
Also, if there are signs of spreading infection, that pathologic resorption we mentioned, or if you simply can't stop the bleeding from the pulp when you're working on it, those are all signs you need a different approach.
Okay. So assuming it is an option, what are the different vital pulp therapy techniques?
There are several, and the choice depends on the exact situation, how close the decay or damage got to the pulp.
Like what?
Well, the simplest is probably a protective liner. Think of it as a tiny bandage placed directly on the dentin, that layer under the enamel.
When would you use that?
This is usually when all the decay has been removed, the pulp itself wasn't exposed, and it seems healthy. The goal is just to minimize any potential irritation from the filling material and give it extra protection.
And you put a filling over it.
Oh, definitely. And it has to be a good seal. A really tight filling is crucial to stop bacteria from leaking back in later. That's key for any of these procedures.
Got it. Okay, liner for minimal issues. What if the decay is really deep, like really close to the pulp, but maybe hasn't quite broken through?
That's where indirect pulp treatment, or IPT, comes in. This is used a lot, especially in primary teeth with deep cavities.
How does it work? You don't take out all the decay.
That's the interesting part. With IPT, the dentist carefully removes most of the decay, but intentionally leaves a thin layer of the deepest affected dentin right over the pulp. The idea is that removing that last little bit might actually expose a healthy pulp, which you want to avoid.
So you leave a bit of iffy stuff.
You leave a bit of affected, but not necessarily infected, dentin. Then you place a special biocompatible material over it and seal it really well. This seals off any remaining bacteria from nutrients, halting the decay process, and encourages the pulp to lay down a new layer of protective dentin from the inside.
Does that actually work better?
Well, our source points out that for primary teeth, IPT actually has a higher long-term success rate than directly capping a small exposure or even doing a pulpotomy. Plus, it lets the baby tooth shed normally later on.
Wow, okay. So sometimes less intervention is more. What if you do accidentally expose the pulp? Just a tiny bit, maybe while cleaning out decay.
Right, a small mechanical or traumatic exposure. If it's tiny, like a millimeter or less, and the pulp underneath looks healthy and you can control the bleeding quickly, then a direct pulp cap might be an option.
And that involves?
Placing a biocompatible material, often something like calcium hydroxide, or even better these days, a material called MTA, mineral trioxide aggregate. It's a biostatement that's really good at sealing and encouraging healing. You place it directly onto the small exposure point.
And the goal?
Maintain vitality again, help it heal, form that reparative dentin bridge, and avoid future issues. In young permanent teeth, it's also critical for allowing the root to finish developing.
Okay, and the last vital therapy technique mentioned is pulpotomy. How's that different?
Pulpotomy is a step further. It involves removing the coronal pulp, the part in the main crown of the tooth, but leaving the pulp down in the roots, healthy and intact.
When is this done?
Typically in primary teeth where decay removal led to a pulp exposure and the pulp seems normal or just mildly inflamed, still capable of healing, or sometimes after trauma.
And what material do you use then?
For primary teeth pulpotomies, the source recommends materials like MTA again, or an older one called formocrysol. It specifically mentions not using calcium hydroxide for this particular procedure in baby teeth. It tends to cause more internal resorption issues in primary teeth compared to the other materials. The goal here is to keep that root pulp alive and healthy, avoiding symptoms and that problematic root breakdown.
Okay, that makes sense. So that covers the strategies for trying to keep the pulp alive. Now, what happens when it's just too damaged? Non-vital pulp therapy.
Exactly. This is for teeth where the pulp is irreversibly inflamed or necrotic, basically. It's dead or dying. The focus shifts completely.
To what?
To eliminating infection, getting rid of the dead or dying tissue, promoting healing in the bone around the root, and making sure there are no lingering symptoms or problems.
Are there times when even this isn't the right call?
Yes, there are contraindications here too. If there's just too much pathologic root resorption, the root is dissolving away, or there isn't enough sound tooth left to build a filling or crown on, or if the bone support is severely compromised, then sometimes extracting the tooth might be the only option.
Right. Okay, so let's assume the tooth is salvageable. What are the non-vital techniques? First up, pulpectomy. How does that differ from the pulpotomy we just talked about?
Pulpectomy goes further. If pulpotomy is removing the pulp in the crown, pulpectomy is removing all the pulp from the crown and all the way down through the root canals.
Like a root canal?
Essentially, yes. It's the term often used for a root canal procedure on a primary tooth. You
Oh.
can clean out everything, shape those tiny canals, and then fill them. But importantly, in a primary tooth, you fill them with a material that can be resorbed or dissolved by the body.
Why resorbable?
Because the permanent tooth is developing underneath, and as it pushes up, it needs to resorb the roots of the baby tooth. The filling material needs to get out of the way too. Non-reinforced ZOE zinc oxide eugenol is a common one.
And what do you do after the pulpectomy?
Our source is pretty clear.
Huh.
The best restoration afterwards for a primary tooth is usually a stainless steel crown to protect what's left. The goal is to clear the infection, stop the symptoms, and let that permanent tooth come in normally.
Okay. Now, I've heard of something called LSTR, lesion sterilization tissue repair. Sounds fancy. What's that?
Yeah, LSTR is a bit different. It's another approach for non-vital primary teeth, especially if there's already some root resorption happening. It's considered less invasive than a full pulpectomy.
How so?
Instead of meticulously cleaning and shaping the canals, LSTR focuses more on disinfection. You clean out the pulp chamber, maybe use a mild acid etch, and then place a potent antibiotic mixture directly into the chamber.
What kind of antibiotics?
It's usually a specific mix, often clindamycin, metronidazole, and ciprofloxacin, in a carrier paste that helps it penetrate. The idea is this antibiotic cocktail sterilizes the area, killing the bacteria, and allows the body's own repair mechanisms to take over.
And then you seal it.
Yep. Seal it up well, often with glass ionomer cement, and usually place a stainless steel crown over it. The main goal is resolving the infection and symptoms without the full mechanical cleanout of pulpectomy.
Interesting. Okay, now shifting gears a bit. What about non-vital permanent teeth, especially in younger patients where the roots haven't even finished forming yet?
Yeah, that's a critical area. When a young permanent tooth with an open, undeveloped root end becomes non-vital, we need special procedures. One key one is apexification.
Apexification, making an apex or a root tip.
Exactly. The goal is to create a hard tissue barrier right at the open end of the root. Since the pulp is dead, it can't finish the job naturally.
So how do you do that?
You carefully remove the dead pulp tissue from the canal, disinfect it thoroughly, often using calcium hydroxide pack in there for a while, and then you place a barrier material, usually MTA again, right at the root end to act as a plug.
Like physically plugging the hole?
Pretty much.
Uh-huh.
Sometimes a collagen matrix is used first to help control where the MTA goes. Once that barrier is formed and confirmed, the rest of the canal space is typically filled with a standard root canal filling material like gutta percha.
What if the tooth walls are thin?
Good point. If the tooth is weak, because development stopped early, sometimes the entire canal might be filled with MTA or a strong composite resin to reinforce it. The overall goal is root end closure, resolving symptoms, and allowing the tooth to function.
That's pretty amazing, guiding the tooth to finish itself, essentially. Then there's regenerative endodontics. That sounds even more space age.
It really does. And it's a very exciting developing field. It's also aimed at these non-vital, immature, permanent teeth.
How is it different from apexification?
Instead of just creating an artificial barrier at the root end, the goal of regenerative endodontics is much more ambitious. It aims to actually regenerate functional pulp-like tissue inside the root canal.
Using the patient's own cells.
Exactly. It involves disinfecting the canal, then stimulating bleeding into the canal space to bring in stem cells and growth factors from the patient's own body. You create a scaffold, seal off, and hope to essentially regrow living tissue inside.
Wow. So instead of filling it with artificial stuff, you're trying to get the body to rebuild it.
Precisely. The potential benefits are huge. Not just resolving infection, but maybe getting thickening of the thin canal walls, even continued root length development. It's replacing damaged tissue with the host's own potential.
That's incredible. Okay, and then finally, for the standard cases, fully developed permanent teeth with irreversible pulpitis or dead pulp.
Right. For restorable permanent teeth, where the has successfully created that barrier, the standard approach is the conventional pulpectomy, or what most people just call root canal treatment.
The one most people are familiar with.
Probably, yeah. This involves completely removing all the pulp from the crown and roots, thoroughly cleaning, shaping, and disinfecting that entire internal canal system, and then filling and sealing it completely with a biocompatible material, usually gutta percha and a sealer cement.
And the goal there.
A successful three-dimensionally sealed root canal system, resolution of any infection or inflammation around the root, and elimination of all symptoms, basically saving the tooth for the long term.
Okay, that covers the main non-vital routes. Now, you mentioned earlier that immature permanent teeth, the ones still developing roots, need special consideration. Can we just recap the key approaches for them specifically?
Absolutely. Because that ongoing root development apexogenesis is so crucial for the tooth's long-term strength and survival, the treatments really try to preserve pulp vitality whenever possible.
Right. So we talked about protective liners, IPT, and direct pulp caps being used similarly, always hoping to let that root finish growing.
Correct. Those are often the first lines of defense if the situation allows.
What other techniques are specifically important for these young permanent teeth?
Well, sometimes a complete pulpotomy can be done on an immature permanent tooth. Again, removing the coronal pulp, but then placing a material over the remaining root pulp that's specifically chosen to encourage that root development to continue.
Okay. And what if decay actually reaches the pulp in one of these young teeth? A cariarious exposure.
For those, a partial pulpotomy is often preferred. Instead of taking out all the coronal pulp, you just remove a small amount, maybe 1 to 3 millimeters, of the inflamed tissue right below the exposure.
Just the very top bit.
Yeah, the most effective part. You need to get a good bleeding control first, that's key. Then you cover that exposed, hopefully healthier pulp tissue below with a biocompatible material.
Like MTA again?
MTA is often preferred here over calcium hydroxide because studies show it tends to lead to more predictable dentin bridge formation and better long-term pulp health. You need a decent thickness, maybe 1.5 millimeter, then cover that with a liner like resin-modified glass ionomer, and then a really good sealing restoration, often a stainless steel crown temporarily.
And the goal is still root development.
Absolutely. Keep the root pulp vital so the tooth can finish maturing. This partial pulpotomy is indicated when you have that cariaceous exposure, but the bleeding is controllable, suggesting the deeper pulp is still healthy enough.
Makes sense. What about trauma if a kid falls and chips a tooth exposing the pulp?
For traumatic exposures in young permanent teeth, we often do something very similar, called a Civec pulpotomy, named after the dentist who pioneered it.
How is it different from the partial one for decay?
It's very similar in technique. Remove 1 to 3 millimeters, sometimes a bit more, of the inflamed pulp below the exposure to reach healthy tissue. Control bleeding. Cover with calcium hydroxide or, again, ideally, MTA. Seal well. The main difference is often the timing. A Civec pulpotomy can sometimes be successful even several days after the injury, though ideally sooner is better.
Up to 9 days, the source mentioned.
Yeah, the evidence seems to support up to about 9 days, but not much longer. The indication is a vital, traumatically exposed young permanent tooth, and the goal, once again, is maintaining vitality and allowing continued root development.
So it really sounds like for these immature permanent teeth, the absolute priority is doing everything possible to keep that pulp alive, or at least the healthy part of it, to let the root finish its job.
Exactly. You're always leaning towards the most conservative approach that maintains vitality, because a fully formed root makes for a much stronger, more resilient tooth in the long run.
This has been incredibly thorough, a really helpful deep dive into, well, the guts of the tooth. So to try and wrap this all up, what's the single most important takeaway message here?
I think the fundamental principle really is understanding the pulp's condition. That critical first step, accurately diagnosing whether the pulp can still heal reversible pulpitis, or if it's damaged beyond repair, irreversible pulpitis or enterosis.
That initial diagnosis drives everything else.
It really does. That distinction dictates whether you're aiming for vital pulp therapy, trying to save the living tissue, or if you need to move to non-vital pulp therapy to clean out infection and seal the space.
And we've seen there's this amazing toolkit of techniques, different approaches for primary teeth versus permanent teeth, for vital versus non-vital situations.
Precisely. From simple liners and IPT, through direct caps and pulpotomies for vital cases, to pulpectomies, LSTR, apexification regeneration, and conventional root canals for non-vital ones. Each has its place, its goals, its specific steps.
And it underscores why that accurate diagnosis, figuring out if the pulp can heal, is just so crucial before you even start.
Absolutely paramount. Making the right call between reversible and irreversible, and then picking the right tool for the job based on the tooth type and situation, That's the key to success.
This has been genuinely enlightening. It's fascinating to think about the body's own healing capacity and how these dental procedures are designed to work with it. It sort of makes you wonder about other areas of health too, right? How understanding these repair processes could be applied elsewhere.
It's a great point. There's so much potential in harnessing the body's own ability to heal.
Definitely food for thought. And for anyone listening who wants to know more, I guess exploring the ongoing research into these dental materials like MTA and regenerative techniques would be the next step. Thanks so much for walking us through all of this today.
My pleasure. It's a complex but really important area of dentistry.